đã được nghe giáo sư trình bày một cái bài rất hay liên quan đến phổi. Và bài này bài thứ hai cũng rất là mới liên quan đến tuyến vú. Sau đó là chúng ta sẽ nghe 4 bài báo cáo của các báo cáo viên Việt Nam. Để bắt đầu chương trình thì tôi xin trân trọng giới thiệu báo cáo đầu tiên liên quan đến ung thư vú, công nghệ mới trong can thiệp ung thư. Now the last section for the ninth Congress.
Now, ladies and gentlemen, it's my great pleasure.
For the first presentation, I would like to introduce Professor Thomas Wolf with the topic New Technology in Breast Cancer in Interventional Oncology. Please, Professor Thomas. Professor Thomas được giới thiệu là trưởng khoa chẩn đoán hình ảnh và điện quang can thiệp của Bệnh viện Trường Đại học Frankfurt. Ông đã có rất nhiều kinh nghiệm trong các lĩnh vực về ung thư, đặc biệt trong các lĩnh vực về điều trị can thiệp ung thư vú, ung thư gan, ung thư phổi và trong một số lĩnh vực điều trị can thiệp mới. Và riêng trong lĩnh vực về vú thì đây là một cái báo cáo mà ứng dụng mới nhất liên quan đến lĩnh vực này. I would like to present Professor Thomas from Germany, from the University of Frankfurt. He is the head of the department of the diagnostic of the interventional radiology at the University Hospital Frankfurt. Now, Professor Thomas Wolf, please.
Now, ladies and gentlemen, it's my great pleasure to, first of all, to be invited at your wonderful meeting. Unfortunately, I could not attend in person due to Corona and the travel restrictions. However, I want to share with you our experience in treating breast cancer with new technologies in interventional oncology. In the following minutes, I want to share with you oncological concepts, the interventional techniques and patient management, the results both for primary breast cancer and for metastases like liver metastasis, lung and bone metastasis. I will share with you new technologies like perfusion, embolization, thermal ablation, and combination of those therapies. I want to start with cryotherapy. Breast cancer, breast tumors, cryotherapy is a well-established method for destroying tissue. It's used in numerous organs like liver, kidney, lung, prostate, and breast. The early detection of tumors supports and accelerates the implementation for local ablation of tumors in tumor therapy. And I give you an overview on the current status in this field. How does cryoablation in the breast work? It was primarily successfully used to treat symptomatic fibroadenomas. The outcome in these benign tumors was a significant volume reduction. More than 80% of fibroadenomas disappear after 1 year of treatment. The risk of incomplete ablation is higher in tumor larger than 2 centimeters. The size is a crucial factor. Most ablations are performed under ultrasound guidance, and the cryoablation has the most favorable risk profile of all ablation techniques in the breast. Advantages are here seen here: low complication rate. We have good cosmetic results. It's done under local anesthesia, outpatient basis. And we have a minimal invasive procedure, and it's painless due to the soothing effect of the cold. Disadvantages: we have an incomplete ablation in bigger tumors. It's the inability to perform axillary lymph node dissection. We have a low capability of limiting the ablation area. And sometimes we need more than one treatment. Well, how we do it? First, we demand a contrast-enhanced MRI in order to detect the tumor, to define its position, to define its tissue characteristics. Then we are doing the ablation under ultrasound or CT guided in local anesthesia. And then the MRI follow-up is 1 day after the procedure, 3 months and 6 months for up to 1 year. Here you see the ice cure system, which is shown here. We have here the nitrogen tank. Here's a visible control panel and the system for inserting. How is the technique? We have 2 important phases. One phase is the thawing. The water flows from the hypotonic interstitial space into the cells, further leading to a cell damage and the bursting of the cells. Additional intercellular water is available for the second freezing process. The damage to the vessel wall leads to a collapse of the blood supply at the microvascular level. After the thawing, damaged endothelium is in contact with the thrombocytes. We have an increased capillary permeability, leading then to an ischemia, and the activation of capase 3 and Bax protein leads to mitochondrial damage. Tumor cells have greater and variable resistance to cold compared to healthy cells. Speed, duration, number of freeze and thaw processes influence effectiveness. 2 free thaw cycles are most effective, ice ball size maximum after 10 to 15 minutes. And what is important, you have to define your freezing process in order, knowing that the speed of the freezing process decreases from the center to the periphery. So sometimes if you don't select it rightly, the freezing process can be too short to achieve a little damage. Ice ball has to extend beyond the borders of the lesion. The border of the visible ice ball is not directly the border of the effective ablation area. So you can say lesion borders at least 5 to 8 millimeters is more than the minus 20 degree zones, which freezes the entire lesion. Here, an example of the ProSense probe from the ice cure. This is done always before we are inserting. There is a test phase where we prove the ice ball in water so that we can get again the information on the design, on where the ice ball is coming according to the tip of the system. We can maximize the efficiency and safety, and it gets cooled for targeted tissue destruction. Application, cooled gas means that the gas is conducted in a thin applicator. We have the Joule-Thomson effect, which means that we affect the temperature after fast expansion using argon or helium. An expansion chamber, the Joule-Thomson effect is located at the tip of the applicator. What should be considered? First of all, it's a patient selection. We have to know the number of lesions, location and size of the tumors, and the possible complications. Before starting the procedure, we prepare a hydrodissection in order to save and serve for possible complications of the skin, the duration of the cycles, and possible minor and major complications. During the therapy, needle position control is important, the size of the ice ball, and complication, especially skin damage in the breast procedure. You see one of our studies, comparative evaluation of microwave and cryoablation for primary breast cancer. And you see for the cryo, we had been so far treating 25 patients, 31 numbers. You see the mean tumor volume shown here with 3.53. And you see the mean range. The mean follow-up had been 6 months, and the range is 1 to 36 months. And if you look at now the results, for cryoablation, we can see that minor complication is only about 10%, major complications, non-technical success rate, 100% compared to microwave, but the technical effectiveness is higher with 96%. Local relapse we have not seen, and the necrosis volume 1 day after treatment was 16.97 cubic, 3 months after the treatment 14, while it was significantly lower. The microwave is only 9 and 7.5 kilometers. Cryoablation also shown here in comparison. Mean age is documented here, mean tumor size, and here are documented the volume. If you look at this area, it is important that if we can get the information, we need to look at cases. Here an example, a 61-year-old patient, tumor size 18 to 14 millimeters, ice ball 50 to 33 millimeters. You see the cancer itself in the lateral component of the left breast. You see the insertion from medial or insertion probe under CT guidance, exact positioning of the 2 markers which are shown here on the tip of the ice. And then at the end you see the ice ball, which has been an ablation area here. And you see some thickening of the skin due to hydrodissection, which was performed by inserting fluid directly under the skin to protect it. mean follow-up. Directly after treatment, you see again the ice ball in the peripheral contrast-enhancing structures, and you see after 2 months a significant downsizing of the ice balls itself, but you don't see a recurrence which would be detected as a high uptake of contrast agent in this lesion. The further follow-up after 5 months and after 10 months, you see the scarring surrounding the ice ball. You see here the contrast enhancement, which is documented here in the peripheral of the lesion. After 20 months, hard to detect, but you can still see the changes in the fatty tissue and the very moderate slim rim surrounding the lesion itself. Parenchymal breast from her previous situation, so this was a full remission in this patient. Is this possible also for lesions near the pectoral muscle? Yes. Here's an example, 60-year-old patient, lesion size 14 to 8 millimeters, positioning lateral posterior to the rectal muscle here, which is documented here. You see the insertion of the probe. We do mostly, we like to do it under CT guidance because contrast-enhanced CT shows it nicely, demonstrates here the lesion itself. And by inserting the ice probe, you see here the positioning. Here you see the beginning of the ice ball, which is nicely documented here. And here you see our hydrodissection needle, which is documented here. And you see why this is done, because otherwise the cooling here of this soft tissue structures would immediately lead to a hypo temperature in the skin area. This can lead to skin necrosis or failure after the treatment. Here's an example, follow-up one with the contrast-enhanced T1-weighted sequence 1 day after the treatment. And you see later, also after 12 months, hard to see or detect the rectal muscles. You find little scarring here lateral to the pectoral muscle structures. Here again, a full ablation. Another example, a recurrent breast cancer shown in MRI, shown in the contrast-enhanced CT scan, positioning of the cryoprobe. You see here the tip, which goes a little, if wanted, about 8 millimeters according to the tip. But the good thing is that the main cooling is done between the 2 electrodes. Tumor size was here 10 to 11 millimeters, freezing for 2 cycles, each 8 minutes, ice ball 39 versus 22 millimeters. Follow-up after cryoablation, you see here, in this area, you see the ice ball is smaller in comparison to the other tumors, but it's surrounding the lesion itself in a way. You see the contralateral side completely without any specific findings. Follow-up after treatment, again, the peripheral rim enhancement, which you see nicely here, also demonstrated in the single view on the breast, however, no active cancers documented. What about fibroadenomas? Fibroadenomas might be tumors with different signal structures. Here you see a quite huge fibroadenoma, which is documented here. On the right side, you see here the inserted ice ball, and it's benign, so we have an exact extension of the cooling temperature according to the tip, which normally should not be larger than 5 millimeters. And then you see nicely the ice ball documented also after using hydrodissection in order to save the skin. After cryoablation, you see the huge amount of necrosis, the devascularization of the fibroadenoma nicely demonstrated here. And this is a very effective means to treat fibroadenomas. You have a good cosmetic outcome if you save the skin and the morphology architecture is fully restored. Recurrent breast cancer, especially after previous radiation or surgery, is a good indication. You see the lesion itself, it is demonstrated here, histologically proven insertion lateral of the ice ball with the antenna here. You see the antenna again, and you see here the roundness shaped ice ball, which is documented here. Complete ablation surrounding structures are documented and without findings. Another example here, before and after cryoablation, the lesion itself here in the medial quadrant, a very tricky, disastrous, and terror to build it. As documented here, and you see after the ablation, you see a complete ablation or zero ablation. Cryoablation of recurrent tumors is documented here. Also, you see here again the lesion itself, the cryo documented here on the pictures on the right side of the hydrodissection. MRI before and after, again shown in the small cancer, the smallest cancer so far we treated with only 5 millimeters. You see here the cryoablation, well documented here with new technology, new navigation system, and you see the further follow-up, you see the complete normalization of the contrast enhancement. Treatments in interventional oncology are also very important for performing treatments directly and combining treatments like chemoperfusion and cryoablation. Here you see nicely documented here a patient with a local recurrence in the breast cancer. We performed 5 chemoperfusions. We were able to downsize the tumors, and finally we ended up with cryoablation percutaneously. You see the infection area here in the peripheral and the upper thoracic area, insertion of the probe, and here finally you see a nice ice ball peripheral contrast enhancement seen in the anterior axillary space. The PET scan after 1 month shows a nearly complete diminishing of the activity of FTG, and you see also in the MRI only after 3 months there are very small remaining changes, and that's something we currently are evaluating to understand the underlying problem. There are different studies also on the use of cryoablation in breast cancer. Here you see an article, Ablation and Management of Disease, which I highly recommend here. And it's demonstrated in many articles, meanwhile, the cryoablation and ablation surgery and the effects of cryoablation on the immune system are possible. There are synergic effects. If you're using cryo, you can also think on other indications like small renal masses, where cryoablation is also a strong benefit for the patient, and also using cryoablation in order to control cancer pain. So in summary, a technique which I wanted to share with you, first of all, the cryoablation is a thin needle-like probe. It's directly from the skin into the tumor. It means no incision, no surgery, no general anesthesia. And because of the cooling effect, it's quite effective for the patients. Leaving the breast, we are now heading to the so-called field of oligometastasis. Oligometastasis in breast cancer means that relevant endpoints are cure, reduction of secondary metastasis, life prolongation, and quality of life. Oligometastasis are evolved from the spectrum theory of cancer metastasis. The progress of cancer metastasis occurs along a continuum from locally confined cancer to widely metastatic disease. If the primary site is controlled or resected, and the metastatic sites are ablated, there will be a prolonged disease-free interval, maybe even potentially cure. So we have always to try it. We have to try it. What are the treatment strategies for liver metastasis? We have systemic or the local chemotherapy. We have tumor entity to know. We have to analyze metastatic spread, skin bonus, or the organs. How is the therapy defined? Curative, palliative, symptomatic, neoadjuvant. How is the local treatment, resection, radiosensitivity, chemosensitivity, thermal ablation possible? I want to share with you this very important treatment decision-making concept. We have the individualized therapy with the individualized patient here in the middle. Then we have all the information on receptor status, mutation status, biomarkers, and that all has to go into the decision-making process, which is so important. Local therapies, what we can do locally, cryo, I heard already, RFA, microwave, laser, focused ultrasound, electroporation, intra-arterial therapy, intra-arterial chemotherapy, SIRT, radiotherapy, and all can be done even non-invasively or open. In the tumor board, we are daily ringing about and discussing what is the best strategy. So what is important, we need information on the staging, on the prognosis, and the location and expansion of metastasis. And we have all the time to define how is the treatment documented. It's a neoadjuvant, curative, palliative, or bridging intention to treat. An example, here a patient became with diffuse, multifocal, still a little bit oligometastasis of breast cancer. The treatment after several chemoperfusion and embolization, we're able to completely downsize the tumor. There were only remaining one lesion here, and a lesion where we tried RFN, but we had also to give it up because of the neighborhood to the adjacent vascular structures. Or another patient, liver metastasis, rarely these patients undergo resection, but here you see a huge tumor near the resection margin invading the vessels. Here you see the lesion itself, peripheral rim enhancement. And then if we see that, we have to discuss our techniques. Do we go for surgical therapies like resection ablation, oncological therapies, systemic or regional chemotherapy, or we have interventional therapies like perfusion, embolization, photodynamic therapy, and so on. And so, honestly, it's documented how we can perform those treatments here, shown on our angiographic suite. And then this is a huge liver metastasis infiltration of breast cancer, hypervascular lesions here documented in the angiography. We've evaluated our patient material. We treated so far 217 patients, multiple 3 to 4 metastases in more than 1,000 treatment sessions. And what is important that we learned that in most situations, we get the patients in a stable disease situation or a partial response. Progression is about 1/3. And the treatment is 2/3 palliative, and then it divides to symptomatic and neoadjuvant indications. The survival rate after TACE is 68%, 2 years survival 43%, and of course we are defining new technology, new areas to go to. Palliative, symptomatic, or also neoadjuvant strategies are important. You see a huge metastasis centrally located peripheral rims. This is due to a metastasis, and you see after the chemoembolization, we have a high uptake of lipyrodol, sharper demarcation, well documented. Or another example here, in breast cancer, you see a huge infiltration and a geographic infiltration starting under the capsule, diffusely infiltrating the liver parenchyma. You see the angiography arising tumor here from the mesenteric superior artery. Not easy, but the effect is tremendous. Look at the comparison. The tumor looked here, and now it looks here. Significant downsizing of more than 30% in a partial remission. If you look at the survival data, you see that if you have patient neoadjuvant, like shown previously, excellent improved survival in this group. If you have median survival, palliative indication, we are achieving the 19-month, and symptomatic indications, we go also for 6 months, which is documented here. Different drugs can be used for TACE in breast cancer, which is documented here. Guiding can be done for laser, radiofrequency, microwave, or also cryo, using monitoring, local tumor control, 5 years survival in the situation. The cure is for the ablation of liver metastasis that we always want a complete ablation. Like it's an example here, centrally in the liver parenchyma localized metastasis. After the ablation, you see there's still a peripheral rim, which is due to compression and tumor extension. This is a complete necrosis, complete documented. Another example of a patient, breast cancer, the tumor near the ascending liver veins. We were not able to tell here the patient that we have to wait another time. Here we decided to control in 10 years after laser therapy. The patient is still free of recurrent cancer. It's still free of new cancers developing in other organs of the liver, not documented, not to see. What are the therapeutic strategy? For liver metastasis, we can say smaller than 5, number of 5 lesions, neoadjuvant chemoembolization, and laser, microwave, or RFA. Tumors lower than 8 centimeters, we have always to start with a palliative chemoembolization. In multiple tumors, we go for symptomatic chemoperfusion and embolization. With some of our publications, which I'm also willing to hand over to you if you just write me an email. So if a patient comes in with liver metastasis, we have to define, is it resectable, is it unresectable? Is it liver dominant? Do we have chunked local hepatic therapies? Then we decide either for the group of vascular interventions, for ablations, or the radioactivation. We can go forward and can use that system also for treating lung tumors. And you see here 3 metastasis colorectal cancers in the lung, insertion of a temperature-based thermal ablation system. And the final end is here, you see the typical example area in the peripheral, centrally located in the centrally middle documented here. And you see a complex lesion here lying lateral, and then it's lying there, the complete ablation. And even in the lung also, we were able to show that 2 years after microwave ablation, you see there are no recurrent tumors, so the patient can survive also the situation. We documented this quite early for the microwave and using pulmonary metastasis. Let me come slowly to the end. Also, RFA combining with kyphoplasty, what we did and learned in the STAR study, can be a helpful method in order to help those patients with the severe pain documented here, the situation. How we do it, we're inserting a cannula, we are approaching the lesion itself, we're performing thermal ablation using radio frequency ablation, and then you see we have achieved ablation here in that area, and now he's inserting cement. But it's important that before we were with the radio frequency destroying the matrix of the tumor. I think that's very essential. And you see the final end. We have tumor destruction by RFA. We have a filling process with the lipiridol, thus documenting us in the further strategies. Let's look at the further definition. Biomarkers of primary tumors in our irrelevant for treatment metastasis. We have to learn more the role of oligometastasis, especially in breast cancer, and ablation therapies, combined therapies are a good option. Thank you for your attention. Hopefully we see us soon in person. If you have special interest, you're always invited to do a fellowship with us here in Frankfurt. And I wish you now a very successful meeting. Thanks for inviting me.